Well, good afternoon, everybody, or good morning, or hello, wherever you happen to be in the world today. A very warm welcome to today's Journal Club. We're going to be talking about 20 years of Candida BSI with a focus on mortality, recurrence, and resistance. And I am especially delighted to welcome Dr. Nneoma Okeke to join Phil and I today to talk about Candida and BSIs. I know it's going to be epidemiological because it's what Nneoma does, and it's going to be fun. And I know that Nneoma's a great presenter, so no pressure at all.
Thank you, John.
Hi, Phil. Hi, Nneoma. How are you?
Really well, thank you. Excited for another Journal Club.
Okay, so this topic is about Candida BSIs. We're not going to be talking much about the dreaded Candidiasis auris. But I know that's an organism that's on everybody's minds at the moment. So, Phil, Candida. What's the first thing you think about when you think about Candida BSIs?
Well, I was going to answer your first question, which is what do I think about when I think about Candida? And I think of the thrush. Yeah, and Candida albicans. And I always remember talking about a lot of that in my kind of PhD in microbiology days. But I think it's really hard to get past the Candidiasis part for me at the moment. It just seems to be on everybody's radar. Everybody I speak to is worrying about it or thinking, when is it going to come to a hospital near them? So I think, I've always known of Candida, but I think that the worry currently, even though I know we're not here to talk about it, is about Candidiasis auris.
Okay, no, I know you've looked at the paper, so you're biased, but what before you looked at it, Candida BSIs, what's the first thing that comes to mind?
Well, yeah, similar to Phil, Candida, thrush, automatic association for me. But yeah, having looked at the paper, it really does remind you the importance of geography when it comes to these infections. So as you will find out, yeah, Candida auris or Candidiasis auris, sorry, is not mentioned in this paper, and it just makes you wonder the influence that we have ourselves as humans moving around the world and spreading these fungi from wherever we are to other places, and really thinking about how did we get here. So it's interesting.
It is very much so, and I've been focused on Candida species, in particular Candidiasis auris outcomes related to BSIs. We've had some cases in London, as has been more and more common elsewhere in the UK and in other parts of the world. So we're really interested. I'm really interested in seeing what the true outcome data is for a serious fungal infection, because so many of the patients that sadly get these invasive fungal infections are so comorbid, but they have so much else going on, and it's how do we disentangle that outcome and potential attributable mortality. So that's a thread I want to pull on as we go through today. Right, Nneoma, before I hand over to you, let me just go through a little bit of background on the Journal Club. So we're aiming to provide some insight into a topical paper as ever, looking to generate discussion. So on that point, you will see a Q&A box in the top of your screen there. So if you have a question, please pop it in as we go through. Don't wait till the end, because everyone always waits to the end and then we get inundated. So put them in as they occur as we go through. It's an opportunity for CPD. We want you to think critically about what you hear, to analyze what's being said and say, well, do I disagree with that? Don't I? Why not? To build confidence so that you can go away and read papers and learn for yourself, and to try and foster a network of enthusiasts, and if you ever can, with a scientific paper, have a bit of fun. So, Nneoma, I'm going to stop sharing my slides and hand over to you.
Thank you. Can you see that?
Yep, can see that.
Okay, excellent. So as John said, we're talking about the paper that looks at 20 years of Candida BSI, the mortality, recurrence, and resistance. This paper is from the Journal of Infection. It's called what you can see on the screen. I'll make sure the link is available if you want to read it after. So a little bit of background. Candidemia, which is essentially Candida in the bloodstream, which will be abbreviated as CABSI from here on out, is very, very deadly, especially when you do get it in the blood, which is candidemia. So it ranges between 26 and 57% mortality rates, and it's even worse amongst those that are immunocompromised or critically ill. We have about 600,000 cases worldwide each year, and that's only climbing, and it's frequently associated with hospitals. So this paper essentially wanted to explore the epidemiology, the characteristics, the microbiology profiles, just what is candidemia, what exactly do we need to know about it in our geographical setting. So what did they do? So this particular paper was based in Australia and an area called Queensland, which has a population of about 5 million. For context, London is almost 10, so about half the population of London, which is really huge. And this was between 70 healthcare institutions and hospitals. And like mentioned, it was 20 years spanning. The data collection, like most epidemiological studies, was retrospective, which means we get it after it's done. And the yeasts were all done to species level using Morley-Toff. So there are some definitions here I won't go through, but one of the main things to look at with papers is to see how they've defined what they're talking about. So if they're talking about a bloodstream infection, what exactly are they looking to say this is defined as, to make sure that you're matching it up with your own policies if you are trying to replicate similar studies in your own setting. So, and another thing to notice with papers are the statistical analysis. What did they use? In this situation, they used a software called Stata, and they've mentioned their version. Again, this is important for reproducibility purposes. The specific statistics they did a survival analysis using Cox proportional hazards to figure out the hazard ratios for the all-cause fatality. And they also did another hazard model to look at the recurrence of candidemia. All of the statistical methods that they mentioned simply, like I said before, so that if you are going to do something similar, you know what they did, and you could do something similar if you wanted to get comparable results. As with all or the majority of scientific papers, statistical significance was set at a p-value of less than 0.05. So what were the results? We had a total of 2,420 patients, and amongst them, they had 2,586 episodes of candidemia across the 20 years. And they have a baseline characteristics table here, which just looks at all of the different parameters amongst all the different species here. I won't go into every single one, but just to note, when you are looking at these kind of characteristics, you want to have a look here at the p-value and note those that are significant, so those that are less than 0.05. And then that would be your way of gauging, oh, is there something that we should actually be looking for as a difference here? For instance, in this first one, you could see age. We have got less than 0.05 here, which means there is a significant difference in the age groups here. And you can quite quickly see that, for instance, this Candida is a lot younger in general than this Candida. And that could mean something for somebody who works in geriatrics, for instance, or pediatrics. So it's important to look at those kind of things when you're looking at the overall baseline characteristics. So the incidence of candidemia in this study increased over time. It went from 2.2 to 3.3. I've just included this visual here because it's very, very, very common to mix up incidence and prevalence. And when we talk about incidence, we're talking about the new cases or the new droplets into the bathtub, which is prevalence. Prevalence are the people that already have it. So we're looking here at the new cases, not the people that are living. Well, you generally wouldn't live with candidemia for a long time, but in general, incidence is talking about new cases as opposed to those that are already there. So they looked at the species trends, how it changed over time, and just split that into two because the first 10 years are a little bit different to the second 10 years. Throughout the entire 10 years, 20 years, the Candida albicans was the most common, and in this chart you can see it's the light pink, the hot pink color. Parapsilosis came in second, which is the green, followed by N. glabratus, which is the yellow. And you can actually see where N. glabratus starts to take over in the second part of the 10 years, and parapsilosis starts to decrease over here. So it's important to see how over time things can change. So if you had a policy back in 2000, it's definitely very different to the policy that you would have in managing them in 2019. They also looked at it by age, and again, this is important depending on the population that you're looking at. You could see that quite clearly over here, englobritis is very, very uncommon in the under fives versus the much older age groups. You can see here that the one in orange is not even appearing in those under the age of 10 and is quite common in these age groups. So looking at them by different parameters allows you to get a better understanding of how to make sure you tailor your treatment to your patient group specifically. When looking at age and sex, we have a bimodal chart here, and you can see that there is a little bit of a peak at the under fives, and that group is actually made up largely of infants, those under the age of 1. And then it slowly rises and we peak around 70 to 75. And it's very pretty much consistent between men and women throughout the entire time. So over here, we're looking at the apportions. So those that are HAHOs or hospital-associated healthcare onset is a bit backwards for us in the UK. We would typically call them HOHAs, COHAs, and COCAs. They've jumbled it up here. So as we expect, majority of them are hospital-associated, which are the HAHOs, 72%, followed by those that are solely community-associated, and lastly, those that are detected in the hospital but assumed to be community. And this is just a chart looking at those, and I will go into a little bit more detail with these. I've just highlighted those that are statistically significant here and draw down a little bit. So you can see when you look at the age, the CACOs are significantly younger than the ones that are detected in the hospital. So if you are getting your candidemia detected in the community, you're much likely to be of a younger population. And you're also much likely to have far less comorbidities than those that are detected in the hospital. When looking at the focus of infection, you can see that HAHOs are largely associated, so those detected in the hospital are largely associated with a focus being soft tissue or abdominal, with abdominal being very, very highly associated to those that get hospital-associated candidemia. And if you have a HACO, you're more likely to have no real focus or for it to be related to your urinary or pelvic area. And if you are a CACO, it's more likely to be related to your head and neck or your lower respiratory tract. When looking at gender differences, the females did not have a good time here. There were increased 30-day mortalities with the females and increased 1-year recurrence, so you're more likely to die within the 30 days. Just to clarify, this is all-cause mortality. So 30 days of any cause so far you had candidemia associated to your diagnosis. You also have an increased 1-year recurrence, so you're more likely to have another case of candidemia if you're female. When looking at the infection rates amongst females, you can see there were certain species that were linked to increased prevalence in females. However, these were not linked to increased mortality or recurrence. Now, what was interesting is if you are a female, you're more likely to have gotten your candidemia if it was from a pelvic or urinary source. However, if you did get it from that source, you were less likely to die. So, you know, polymicrobial BSIs were also more frequent in females compared to males. But when it came to comorbidities, those that were malignant and older age were more likely to be males compared to females. And when it came to fluconazole resistance, again, it was higher in females. So talking about antifungal resistance, overall it was generally low. There was only 3.2% resistance, and it did decline over time. So it went from 4.5 in the first 10 years down to 2.2 in the second 10 years, and that was a statistically significant reduction. And with echinocandins, again, it remained very, very low. This is another group of antifungals. So fluconazole, the azole group, echinocandins are another group of antifungals. And we check them to see, basically, can we still use this to treat these infections? And that remained very low, and it didn't really change much, and even the change wasn't statistically significant. And overall, like I mentioned earlier, there were, fluconazole in females and infections fluconazole resistance much higher. And again, this is just what we discussed, just visualize so you can see the resistance, but also where we saw them in which species. So you can see Candida parapsilosis is really taking over here with the pinks, and then you've got a lot of greens, so the N. glabratus as well. And a similar picture with echinocandins, where you can see N. glabratus generally has the majority of the resistant profiles. With mortality, we have a 30-day all-cause mortality of about 21%, which didn't change too much over the 20 years. We had a 90-day mortality of 28.2% and a one-year mortality of 36.9%. So very, very high mortality with these candidemias. With higher mortality, you're more likely to be those of older age if you had an ICU admission or you had a higher comorbidity burden, so you had more illnesses. If you were infected with Tropicalis, it does show that there is an increased hazard ratio, but it's not statistically significant. So it's just something that we would note to keep an eye on in case it changes later. And protective factors, it was actually found that if you had diabetes mellitus, you were less likely to die. You had an actually 38% hazard reduction, and that is statistically significant. If you had your infection source being urinary or pelvic, you were less likely to die. And if you had an endovascular one also, you're less likely to die. And with the species in general, if you were infected with the parapsilosis, you're also less likely to die. So if you are to get a candidemia, be a diabetic and get it through your urinary system, and make sure it's Candida parapsilosis. Okay, recurrence. So 104 patients actually had a recurrence of their candidemia after their first infection, with a total of 270 episodes. So 67% had a single recurrence, and 82.9% of those happened within 6 months of the first episode. Bear in mind, this doesn't consider patients that may have been lost to follow-up. So with species trends, you can see that with Candida albicans, it's less common in recurrences. So we actually had about 42.4% being an index case. And then following on from that, it's less likely to be Candida albicans, which was interesting. And I'll show you the visual of that here. So you can see this is a chart of the recurrences. And I've just put a red arrow wherever there was a Candida albicans, which had a recurrence. However, the recurrence was a different species. So you did test positive for another candidemia, but it wasn't Candida albicans, and specifically Candida albicans was notorious for that. So what are the strengths of this study? It's a very large population-based data set. It spans 20 years. It's a huge, rich data set, and we can really get to understand a lot of the bits and bobs that concern Candida BSIs. It's comprehensive, it has low missing mortality data, which is really good for a study like this, and it provides insight into long-term trends and species distributions and resistance. However, the limitations, there will always be limitations. It is retrospective and observational, which is always at risk of bias and confounding and sampling bias. It's just it's something you will always see when it comes to observational studies. It's got limited treatment data, so we weren't actually able to assess the effectiveness of treatment of these patients. So we're only able to figure out all of the parameters we've discussed, but not to see how effective the treatments were with them. Now, it was only taken from Queensland. We don't know how Queensland healthcare works in relation to even the rest of Australia, talk less of the rest of the world. So if you were going to try and compare this to somewhere, you would want to use somewhere that is geographically maybe close by, or somewhere that has a similar kind of healthcare system, but it'd be quite hard to figure out the right proxies to use to make sure you could compare these apples with oranges. And we have limited comparable studies. In fact, I don't think there are any really comparable studies with this level of data. So in conclusion, this is a longitudinal data study from Queensland that shows the Candida species trends. Candida albicans went down, N. glabratus and Candida dubliniensis went up. Tropicalis remains concerning due to its link with higher mortality, so we have to keep an eye on that. Antifungal resistance is low, and it's recommended that you can continue using echinocandins for empiric therapy. Gender and species-specific risk patterns suggest a need for tailored treatment. We need to help the females, basically. And Candida bloodstream infection remains a serious healthcare problem related to incredibly high mortality. Thank you.
Okay, thanks, Nneoma. That was fantastic. I really enjoyed that. I like what you did with the paper. I like the way you made it so digestible and understandable. I did read the paper yesterday and I found it quite hard going. So the way that you've distilled it in such a clear way and flagged the key points to us is great. So please do, let's get some questions coming in for Nneoma that we can kick off the discussion with. I mean, I've got so many questions that I've written down. I don't know actually which one to start with. So I think, like I said at the start, mortality is where I started with this paper, and it's got some really interesting outcomes. 21% of the patients with a Candida species bacteremia died within 30 days. Just off the bat, how do you interpret that? And is it as alarming as it sounds?
Again, because it's all-cause mortality, I always tell people to take that with a pinch of salt. What that definition is we have detected Candida in the blood, and within 30 days they've died. So we don't know what has happened to them up until that point. But I think one of the things we have to consider is that for you to get to the point where you have candidemia and it's taken over to the point that it has, you're probably not very well to begin with. So that may not be the sole cause of your death. So when I see those numbers, yes, it is alarming, but I always consider the fact that they haven't determined that this is solely, the death wasn't solely due to Candida.
Yeah, I agree. And I'm pleased you said that, because I feel the same, that 21% mortality rate, all-cause mortality 30 days, has a potential for misinterpretation, particularly in the C. aureus era. Somebody might say, 20% of patients that get C. aureus are going to die. You can see the headline in the tabloid, but it's not like that. These patients are comorbid, have serious underlying conditions, and many of them sadly would die anyway, with or without the BSI, and perhaps it's the terminal event. So related to that, how would we ever begin to develop an attributable mortality related to Candida BSIs? What would be the process we'd need to go through to get to that point?
It would be, I think you'd have to have a situation where we could determine that they were well enough before they had the BSI to be able to attribute it to them. And I don't think that will happen, because generally, well, people don't get this. So I'm sure there are some algorithms or models we could use to try, but in reality, it's one of those infections that is associated with those that are critically ill or have higher immunocompromised states. So separating the cause of death from what they would have probably already died from is going to be pretty hard.
Okay, yeah, I mean, I agree. I think it's so hard to really tease out attributable mortality in this patient cohort that are susceptible in the first case to an invasive fungal infection. Okay, I'm going to be quiet and let Phil come in.
Yeah, thanks for the presentation. It was really interesting, fascinating amount of data as well. A couple of questions I had, but you talked a little bit about prevalence by gender and talking about higher prevalence in females. By the way, I love the bathtub and how that demonstrates the difference between incidence and prevalence. It's a really nice way of describing it. Was there anything that stuck out to you from the paper about, the risk factors in females, or why the incidence in female gender was higher than males?
I wish I had more of an explanation. It really shocked me. I don't know why, but I assumed it would be higher in males. I really did, simply because with our own Candida auris cohort, we have a lot more males. So it was quite eye-opening to see that actually when it comes down to candidemia and not colonization, it's a very different situation. But I didn't really get too many answers as to why.
Mm-hmm. Okay, interesting. Might be good as a follow-up. John?
Yeah, I was going to ask a similar question actually about mortality in females and why the mortality outcome was more common in females, but I guess that's the same answer. We don't really know. It's not very clear from this study. Leo's asked a really interesting question about diagnosis actually of invasive fungal disease. I think it's true that around 50% of invasive fungal infections are never culture positive. So if we're relying on only culture data, we're going to be missing a hugely significant proportion of invasive fungal infections. And there's tools we can use like BGD or PCR or antigen-based methods that kind of enhance our ability to detect and get patients on the right empiric antimicrobial therapies. Do you know how they brought patients into this study in the first place? Was it laboratory-based diagnosis?
Yeah, so it was retrospectively collected data from the laboratory diagnosis, but I think they mentioned that everything was processed using MALDI-TOF, mass spectrometry. Let me just double check.
Okay, so there would have been a mass spec confirmation. And related to that, there's a follow-on question around the use of invasive devices and vascular access devices, and that would be an interesting question to answer really, because I'd imagine a proportion of these invasive fungal infections would be preventable if we got our vascular access devices better managed, if we inserted fewer and took care of them when they're in. I guess that wasn't really a feature of this study, but might be something for future analysis.
Yeah, so with these kind of studies, it's generally done by the government type population health team. They wouldn't have hospital level data. So that's where they would be at a disadvantage versus somebody like GSTT. We would be able to pull that kind of thing out and have a more rich data set. So definitely a limitation.
Thanks. There's loads of questions in the chat now, which is great. So John and I'll try and work through them. So a question here about antifungal resistance and whether or not there are any factors associated with increased resistance in recurrent infections. Don't know if you managed to pull that out of the study.
If there were any increased...
So if there are any factors associated with increased resistance to antifungals in recurrent infections.
No, they didn't mention that. Again, because they will only be pulling this based on laboratory data, they won't have intimate patient data to be able to give us anything on that.
Okay, thank you.
Yeah, and I suspect, Katie, your question may be a similar answer really. It's around azole resistance and whether that's explained by an increase in Candida glabrata versus other species. And I suppose that was a bigger question I had, was whether the relatively small changes in antifungal susceptibility, were they all attributable to just the species changes, or were we seeing increased antifungal resistance within a single species over that 20-year period?
N. glabratus was definitely associated with more resistance than the others, but without more data, I can't make any assumptions. It's I'm a stickler for making sure I dot my I's and cross my T's, so I don't want to give you an answer. But it is a good question. I will say, for those that are interested in the hospital side of things and how you'd get the more data from all of this, we do have, I'm just plugging our paper out there, John, case control on Candida auris from GSTT, which will hopefully be coming to your doors soon. And yeah, just keep an eye out for that. And that does go into more detail on the clinical side of things.
Okay, good plug. Very happy with that. Phil?
Sorry, just looking at my notes. There's a lot of questions around resistance to different antifungals. There's a good question here about how these findings compare with global trends in Candida species prevalence. I don't know if you've got any thoughts or insight on that.
No, yeah, it's a really good question. That's what I was trying to infer in the beginning when we were talking about Candida auris and the geography of Candida species, because throughout the 20 years, they didn't detect not one Candida auris, and we're inundated with them. So it's really quite interesting to see how it can differ so vastly, but also again looking at how similar they are in that, when you saw the recurrences, you saw that a lot of the time they will get infected with a different species completely. So I just feel there's a lot about Candida and fungi in general that we don't quite understand.
Hmm. Yeah. Separate to the questions from the audience, I had another follow-up question. The data stops short of the COVID pandemic, so it finishes, I think, in 2019. And I just wonder if there was any, what the impact of the COVID pandemic might have been on the prevalence of some of these species.
Interestingly, because we had that global lockdown, I don't think it would have been as dramatic as if this were post-pandemic, because we had almost a global standstill. So that movement of people from one country to another and encouraging the spread of the microbes would be vastly reduced. So I'm pretty sure it'd have pretty similar picture to what they currently have right now. If anything, Candida auris might only just now be emerging.
Hmm. Do you think then that the movement of people is kind of the key to the changes in the incidence of these species? Or do you think there's anything that might have happened post-COVID in, I don't know, potentially using more antibiotics, or, the way that patient care might have changed post-COVID that might have an impact on prevalence as well?
Oh, absolutely. Everything. I believe environment, antibiotics, global warming. I think everybody's to blame. This isn't one man's problem for sure.
Cheers, John.
Okay, can I just say we've got some brilliant questions in the Q&A today. So fantastic, keep them coming. This is a good one. Given the absence from Sangam, thanks. Given the absence of treatment data in the analysis, how can we be sure that the observed differences in mortality and recurrence across species and genders aren't confounded by the treatment data that we don't have in the paper? So could it be the differences in treatment are actually the underlying reason for the outcomes in terms of mortality and recurrence across species and genders, rather than any of the factors that were measured?
Short answer, absolutely. Long answer, with studies like this, you control for confounding factors, even the ones you can't quite see. So they would have taken certain statistical measures into consideration to try and control for that, especially considering the vast data set. We have to assume at some point we have an average of sorts, and then your results are comparable. But short answer, yes. We could, for all we know, North Queensland could have been given them premium treatment, and the South just said, to hell with you all. We don't know. We don't have the answers, so absolutely.
Okay, that's a really interesting idea about controlling for variables we can't see. I'm struggling to get my head around that, but that's probably for another day. Phil, do you want to take the next one?
Yeah, I'll take Catherine's question. Catherine's talking about the impact of ethnicity, and whether or not people identified as Aboriginal, and other inequalities. So I think the question is basically your perspectives on the fact, different communities often access services in different ways and may experience varying levels of treatment. I completely agree. So any impact on whether or not, those type of things around ethnicity or health inequalities kind of impact on the prevalence of some of these Candida infections?
That's a really, really brilliant question, and I'm really into health inequality. So yeah, I looked for that as well. But again, I can't blame them. They are dealing with a very general data set. They're limited. It would have probably been de-identified as well before they even had access to it, so they wouldn't even be able to get that level of data. But absolutely, in an ideal world, we would be able to break it down by ethnicity. We have seen consistently across the board that there is differences in treatment, survival, all of these parameters when it comes to ethnicity. So it is something that does need to be considered in any paper.
Yeah, we had Kerry Holden on talking about health inequalities, I think at the beginning of the year in January and February. And it was just fascinating to see, how much more impact there is in some of those areas of our society, where things like deprivation and, living below the poverty line have an impact on susceptibility to infections.
Yeah.
Thank you. John.
Yeah, so thinking about the overall findings here, how can we use this study to influence our practice and make changes for the better in what we do? I suppose I'm thinking particularly in terms of prevention, but also in terms of infection management as well.
Funnily enough, one of the things I took from the paper, this is abstract thinking, it mentioned that diabetes was protective. It mentioned that those that had endovascular procedures were protective. So to me, what that tells me is there is something that we're doing clinically with these patient groups that is somehow making them less likely to die. Is it that enhanced care? Do we need to put that level of enhanced care or whatever we're doing differently with them to these other patient groups? Could it be specific treatments that they're getting? I think it's more about investigating what are we doing for those patient groups, especially with us in Guy's and St. Tommy's, we have majority of our cases in vascular wards. So how are they being treated? What are we doing differently? And is it something we need to think about extracting and applying as policy when it comes to managing candidemia patients?
Thank you. Great answer. This might be a really tricky one to answer, but I'll play devil's advocate. If you were looking at this result published for the next 20 years' time, where do you think the trends might be? Do you think it would be a similar picture or a very different one?
Where are we looking?
Well, let's stay with the same. Well, maybe global. Let's talk global.
I think global is going to be all over the place.
Mm-hmm.
The world is changing very, very quickly. People are moving a lot.
Mm-hmm.
The climate is changing. Antimicrobials are not working anymore. So I think we're going to see a very, very different picture, and it's going to change very, very quickly.
Agree.
I think you might even argue that if you did the same study now in a global setting, you'd already see a very different picture.
Absolutely.
I mean, C. auris is essentially 100% fluconazole resistant, so that would be a big change. I think you'd see, and we know from I was reading a study from was it Saudi maybe the other day where C. auris is essentially taken over as their healthcare associated Candida species. So that's a big change to susceptibility profiles. I had a really good question. Oh yeah, that was it. So thinking about the aims of our journal club here to try and kind of engender confidence in reading these studies. This paper was quite hardcore epidemiology, and you mentioned a little bit about statistical methods as we were going through your slides. What's your advice if you're sitting there, you're reading a paper and you just don't understand the statistical approach they took? It's just above your statistical pay grade. What do you do? What are your tips? I mean, that never happens to you, obviously, but imagine a scenario where it did, if you know.
Yeah. I'm a stickler for tables. I love summarized data. I don't like looking at the actual text to find anything. I find it quite confusing, and it's never really as robust as you want it to be anyway. I like to, similar to what I showed you, find the ones that are statistically significant and highlight them. Those are the ones I'll drill into, and I'll try and make sense of those. So look for anything that is less than 0.05 generally, not equals to 0.05 because that's borderline, less than 0.05. And those are the things that you can start to say, okay, let me look and see what's going on here. What are the parameters we're looking at? What potentially could we be looking at that is statistically different? So I would say if I really didn't know what to do, I'd stick to the tables, and you will get the answer you're looking for, because generally that's the best way to present findings.
Okay, that's really good advice. Thank you. And I think that's something I probably do myself because I'm not a statistician. I have a rudimentary understanding of biostats, but nothing complicated, and I don't pretend to understand the detail. I suppose I put some trust in a journal system where somebody at some point with the right expertise has looked at this paper and said, yeah, that's an appropriate statistical method to answer that question. So it's maybe less important to fully understand the details of the model, and it's more about getting used to interpreting the outcomes and what they mean and what's significant and what isn't.
Exactly.
Yeah. I think we've got time for one more question. Sangam asks, what specific infection control interventions, such as catheter care bundles or environmental decontamination, do you think should be prioritised or re-evaluated, considering that the vast majority of the bloodstream infections were hospital acquired? I think that's a really good question.
I think all of them. I
Mm-hmm.
don't think there is any one part of IPC that shouldn't be reevaluated, especially now with all of the challenges that we're facing, not just Canada. I think since COVID, I think it's really opened our minds to seeing we're actually dealing with a lot of unseen enemies, and we need to start updating our approach. We can't do what we were doing 20 years ago. Even the paper we just discussed has shown you just how much the species demographic has changed in just 20 years, which means we need to actively start looking at what are the new technologies out there, what are the new products out there, what can we do to really start to tackle this head on? Are there different ways we need to approach them, different types of education we need to roll out? I don't think there is any single aspect of IPC that doesn't need reevaluating on a constant basis until we get all of this under control.
Yeah, I couldn't agree more. There's no silver bullet, and these organisms will continue to evolve and adapt. So yeah, we need to do the same. Okay, John.
Okay, well, thanks, Nneoma. That time's gone incredibly quickly. Time flies when you're having fun. So thanks again for coming and joining us today and sharing your expertise to interpret that paper. So hopefully you can see what's next for the Journal Club. In a couple of weeks' time, we've got Dr. Jude Robinson talking about empowering patients to improve hand hygiene. Early October, Dr. Alexandra Peters will be talking about environmental hygiene and how we can make improvements. And then later on in October, Dr. James Price will be questioning whether whole genome sequencing for IPC is worth it or not. You can look at the up-to-date schedule for Journal Clubs on the website there. All previous editions are available on YouTube. And finally, on behalf of IPC Partners, thank you for joining us today, and we look forward to seeing you next time. Thank you and goodbye.